All right. So we have people trickling in. Just the first couple slides is just basically an introduction. So I'm just going to get started here. Um, the topic of my webinar tonight, and thank you for joining and spending some time with me, is on anterior deprogrammers, the what, the why, and the how. And just a little bit about me, I'm just right outside of Philadelphia. I'm actually wearing my Kelly green in preparation for the Super Bowl on Sunday. So sending out good vibes on my Eagles team here. I am a full-time practicing practitioner, and I have an awesome opportunity to be able to teach at the Institute. I also teach the microscope restorative program at Penn. That's 1 day a week. And between balancing a work-life balance, between a lifelong learner, having a mommy life practice and with dental practicing, I'm really happy to be here. So here we have a start code, and you want to take a picture of that and scan so that you can download your CE credit letter here at the end. So I'll leave that up for another second or so. And I want to thank Dr. Lee Brady and the Pankey Institute for having me. The Institute has been honestly so impactful in my life, both professionally and personally, and it continues to allow me to be a better version of myself as a lifelong learner. And I am just really honestly so grateful to be able to give back. I have no conflicts of interest to disclose for everyone today. The topic of today is obviously anterior deprogrammers. I know this has been discussed in previous webinars and other educational platforms, and I promise you, I think this topic is going to be coming up more and more in dental education as it has so many applications, and mastering this concept can really be impactful for your practice and for the patients. So tonight, I just kind of hope to layer on the knowledge by authoring my own learning on this topic and share with you some key pearls that has really helped me to use this appliance in so many different ways. And I will share with you today that I learned the real quote unquote magic and what anterior deprogrammers can provide us as clinicians and for our patients through an incredible mentor and educator that captured the hearts and minds of so many of us, Dr. Herb Blumenthal. He would talk to us about the stomatognathic system, making craniomandibular connections, which you will be able to see tonight. And so I dedicate this presentation to Dr. Herb Blumenthal, where I learned the magic in anterior deprogrammers. He was faculty at the Institute and headed a study club called the Acorn Group, and his teachings and philosophy, it just continues to live on. So with that being said, let's get going. So we have basically, if we're talking about the category of appliances, and just to be complete and share with you all the other 5 other main categories we've got here. We've got a full coverage appliance, which is in my practice a workhorse appliance. And by far it's that, and along with the topic tonight, which is the anterior deprogrammers, are the 2 appliances that I implement in my practice all the time. We teach a very comprehensive course at the Pankey Institute. It's essentials courses, and those of you that may be interested after tonight want to learn more about appliance therapy, I can put up some information about that for you as well. So what's after appliance therapy? And so we want to think about either restoring teeth. Once we have stability and adaptability and we achieve our goals and what we want in appliance therapy, we can think about putting teeth in a better position, orthodontics. We could equilibrate, which I think is a really fundamental skill for us to be able to master. And I actually call it bite harmonizing. Who wouldn't want to have their bite harmonized? We can also phase dentistry. And what I've learned that's been really impactful is, patients are really appreciative that appliance therapy is and are able to help them phase dentistry. So, I always say not now doesn't mean not ever for patients, because we're doing dentistry with and for them. So appliance therapy, all of us collaboratively on this webinar tonight can probably come up with more than 20 different reasons why there's benefits to appliance therapy. And just the key few ones or concepts would be there's a relief of symptoms, muscles and joints. We can confirm our diagnosis. We can mitigate parafunction and it can become a protective appliance. We can address occlusal muscle disharmony, phase treatment in dentistry, verify or aid in record taking in centric relation. There's definitely a patient education piece with co-discovery, and it does give us a really great preview of the next steps for restorative. And I just want to bring your attention to the two top ones here about just relief of symptoms, being a therapeutic appliance, and also confirming diagnosis, because I feel like that's kind of where the lion's share of the first half of the webinar tonight is going to be. And I want to go into and talking about, and I love this quote, describing chronic pain. It's from the Trigger Point Manual with Myofascial Pain and Dysfunction by Trebell and Simon. And they describe chronic pain as the brain enslaved by pain. Chronic pain is the most common cause of disability and unemployment at just annual costs of just billions of dollars in healthcare. And it's described as pain lasting for more than 3 to 6 months. And I know that we all have suffered or endured some type of chronic pain, and especially like myofascial pain or muscle pain, which is related to trigger points, which I'm going to be talking about shortly here, but it's the energy around hypersensitive top bands and that elicit pain someplace else. And I describe this as sort of knots for patients when I'm doing a muscle exam or when they're describing their muscle pain. So keep that in mind, because then I want to go into just talking about so we're talking the same language. We're sort of starting on the same point. Is just a simple definition of pain. What's pain? It's an unpleasant sensory emotional experience associated with actual or potential tissue damage or described as such damage. And there's different varying types of pain. So we've got primary pain, where pain is where the site and source is in the same location. And so simply here, you're going to see from this slide, there's a toothache. It excites the trigeminal nerve, and the nociception to pain goes down the spinal tract nucleus, and then another neuron picks up and is excited, and then the senses goes to the reticular formation in the thalamus, and then it's like, whoa, there's an injury, and then they have to go to the cortex, and their sensory pain is stimulated. So this is where pain is felt. So the site and source is the same. There is another type of pain which is associated with more of our chronic pain that comes into play, and that has to deal with the heterotopic pain. So this is secondary pain where site and source are not in the same location. And when we break down heterotopic pain, and in scope of this webinar tonight, I'm just going to focus in on the referred pain, but this is where site and source is not the same. So we've got this convergence theory, where in a convergence theory of neurons are converging together in one central neuron, and there's also divergent neurons where all the information coming in comes in, and then it separates out, and all of them are all of the neurons are going in and out. And then, the nature is so smart, right? Because we don't have all the neuron connections being wired under one. So the collateral pathways allow our body to keep going even if other pathways don't work. So technically, it's actually an amazing protective mechanism, but when pain referral comes into play, it gets complicated. So we've got this nociceptive pain input causing excitatory information in the brainstem, and then a couple of other neurons then communicate, and then ultimately the pathway goes up to the reticular formation, goes to the thalamus, and then goes to the cortex, and ultimately you're feeling pain in some other places where site and source is not the same. So this is where sort of pain information and the signs and symptoms, it gets a little messy. And what's just actually really fascinating is this homunculus graphic sensory cortex. It's unbelievable to me and really neat that 45% of what we feel is all dedicated to the face, mouth, and throat. That's almost half of everything that we feel is coming from everything from above the head and neck area. So where I'm going with this is that just with oral facial pain and TMD, and it's such a big, some say it's, can get confusing and there's such a big umbrella term. And here's a cover story regarding oral facial pain regions in patients visiting a general dentist, and they specifically focused on the Pacific Northwest. And they took 1,600 patients visiting 100 general dentists, and what they found was the prevalence of TMD. 1 in 6 patients visiting the dentist had experienced oral facial pain. And more interestingly enough, muscle pain is twice as many as joint. So, and both of them are treated quite differently. So, and we have to make a diagnosis first. In the realm of TMD, this is, in my humble opinion, this is a problem for dentists, but it's not always a dental problem. TM disorders is a subgroup of oral facial pain disorders, and we really have to be the specialist for our patients. They really need us because our patients will go to ENT, they have pain referral patterns, or they'll go to their dentist, and dentists, they don't know. Some dentists don't treat TMD. And so there's a circular cycle, and I want us to be more aware that we do really have the ability to treat our patients, and the patients need us. So then let's now shift into the anterior only appliance. So an anterior only appliance is a family of appliances characterized by having no posterior occlusal contacts on the appliance. So all the occlusion is on anterior teeth and all excursive movements. Now, this is where it gets a little confusing because there's a lot of anterior only appliances. And why, I'm going to ask you, are there so many names? Well, sometimes it's named after the person developed it. It depends on how many teeth they're touching, depends on the company. There's so many designs and purposes, but ultimately the principles are the same. So I've sort of broken down the most common names of anterior only appliances. So we've got the first 3 up here on the screen. It's Anterior Deprogrammer, Lucia Jig, Pankey Bite Stop. I think most of us here on this call may have heard about all 3 of them, maybe one of them, but that is like that top little appliance up on the top left screen. So those 3 are described that. And then we've got your diagnostic palatal anterior stop. So that is shortened for DPAS. And that was developed by my friend and colleague, Dr. John Droder. And that I'm going to coin or put that one in with the Coist deprogrammer. And that's like that second one down there. So those 2 principally have the same sort of design. And we'll talk about that a little bit shortly. And then we've got the quick splint there, and then we've got that lower screen has the B splint, and it's the idea of the NTI. So that's all sort of coming together, and ultimately the principles of the anterior only appliances. It's anterior only, posterior disclusion, mostly but not limited to uppers. There cannot be any posterior tooth contact. We never wear it full time. And for me, I recommend it for my patients to only wear it nightly. So what does anterior deprogrammers do? Well, there's a lot of reasons, and all of them here, or most of them here, are on the screen. It deprograms muscles. You can treat muscle-related tension headaches. It decreases elevator muscle activity. It allows for seating of the condyle. It releases the lateral pterygoid muscle. It can protect your provisionals and your dentistry. You can use it to aid you in centric relation record taken, and it can be a really powerful diagnostic tool in assessing joint versus muscle. So I've got it in exclamation point, the very top one that says deprogramming muscles. And that's the powerful message here with anterior deprogrammers. It allows for muscle deprogramming. What that means is the process that relaxes muscles in the jaw and in the maxillofacial region. With a dental deprogrammer, it breaks the jaw's habitual muscle memory and muscle engrams. So the purpose of muscle deprogramming is to relax and reduce muscle activity, to eliminate muscle tension, and allow for accurate examination with condyles seated in the fossa. And as I mentioned, the nociceptive trigeminal inhibition, which is short for NTI, this has been shown to relieve migraines and tension type headaches through the afferent pain from the masticatory muscles affects the central nervous system. It leads to increased blood flow, increasing in migraines. And so this the anterior only appliances, it reduces the muscle sensory feedback that can reduce migraines as well as the tension type headaches. Here are one of a few studies, and there are many more if you actually want to learn more about this, but it's the anterior bite stops, decreases the muscle activity, decreases the elevator muscle activity, impair function, and also you can utilize the bite splints to create more accurate records in a seated condylar position. So these are some studies that are out there to support that. And I also want to say, as I talked about the why and the how, and I also want to talk about the limitations really quick with anterior only appliances. First of all, we never want to wear this appliance full time. It's nighttime only. If we do, we run the risks of anterior teeth intrusion, posterior teeth extrusion. We also want to watch out for patients that do not have muscle inhibition. So we want to check for full power on anterior teeth. With posterior teeth discluded, if the patients are able to still fully power down and really activate their elevator muscles, this appliance is not for that patient. And also if you have an anterior only appliance in for the patient and there's pain. So if the patient reports pain, you wanna consider a different appliance, because our working diagnosis would include inflammation in the joint or retrodiscitis or some type of inflammation. We want to consider a different appliance. And in my practice and in my hands, I would consider going to a full coverage appliance that will support the joints and the muscle. And then also this last concept of mandibular repositioning. So almost like muscle deprogramming really taking to effect. So if there's more of a bigger AP discrepancy between a seated condylar position and their maximum habitual biting, if there's a really big spread, we run the risk of just the mandible wanting to stay in the retruded state, staying in a seated condylar position. So here is a video showing an anterior deprogrammer going in and the mandible is seating into centrifugation. So we know that at this position here, as you see, and that's the Pankey bite stops, that's the Lucia jig, and that's the anterior deprogram that I described. So we've got the lateral pterygoid muscle is relaxing and the condyles are seating. And you can also see it in this picture here. I've got left screen here, I've got maximum intercuspations where the lateral pterygoid is contracted, holding the condyle down and forward, and the patient is in maximum intercuspation, versus a seated condylar position. The deprogrammer seats the condyle and the lateral pterygoid muscle is relaxed and the jaw is going down and back. So I'm thinking about the situation with the photo that I just shared with this patient. So this patient has had fremitus, sensitive teeth. As you can see here, there's a number 7 crown on there, and in my opinion, I still don't think that tissue looks very healthy. There's fremitus, patient has popping and clicking, muscle pain. Also in this patient, in this story, the patient has some sleeping issues. And so if I were to imagine not just what the teeth looks like, but just what the condyle looks like, if I see cases in fremitus, this is where my brain goes. My brain goes to, how does a teeth look like? Is a mandible trapped underneath the maxilla? Is the jaw in quote unquote jaw jail? And what do the condyles look like? So So this is one I really want to utilize appliance therapy and anti-deprogramming to really understand where the condylar position is. We've probably all seen so many slides on centric relation, but just to be complete, it's the most stable position, hence, as it says here on the screen, MSS, most stable position. It's independent of tooth contact. The disc is in the most anterior superior position against the eminence, and it's a repeatable reference point. And at this position, the lateral pterygoid muscle is not contracted, and the condyle is fully seated. So with this patient, as I mentioned, patient has chronic headaches, muscle pain, patient has neck pain. We talked about sleep studies. You can see the thick buccal buttressing of bone there and a lot of anterior wear. My brain goes to airway. And I'm also thinking my thought process of treatment has completely changed because without orthodontics, I don't know how I'm going to improve the fossa and cusp relationship of the teeth. So joints are important. Seated condylar position plays an incredible role, and anterior deprogramming can definitely help us to understand where the treatment position should potentially be. So in order to know dysfunction, we have to understand function. So I just want to briefly, just a couple of slides here, talk about just a review of anatomy of the condyle disc assembly. And it's so incredibly dynamic, right? Where the disc is attached to the condyle, and like Pete Dawson would say, it's like a bucket handle with the medial lateral pole, and the disc goes along for the ride. And right in front here, you would have the lateral pterygoid muscle attached to the condyle and the disc, which originates in the sphenoid bone. And keep that word in mind, the sphenoid bone, tucked away in your brain, because it's going to come back later. And distally attached is the posterior ligament, and all the vascularization is in the retrodiscal tissue area. So super, super dynamic, translates and rotates. And as we look at the next slide here, I want to dial in the lateral pterygoid just a little bit more. It originates in the infratemporal fossa, or the bone of the greater sphenoid bone, and the lower head originates from the lateral surface of the pterygoid plate. And it inserts in the disc, the capsule, and the neck of the condyle. Really, really fascinating. We've got this really thin bone, and on the lateral aspect of the pterygoid plate, we've got the lateral pterygoid muscle, and a medial to that is the medial pterygoid muscle. So keep that in mind. So as I talked about earlier, the chronic pain, where we talked about that heterotropic pain where site and source is not in the same location, I want to bring your attention to sort of a hyperactive or myofascial pain in the lateral pterygoid muscle. And it can lead to pain in the joint, the sinus, the superior and inferior belly of the orbit, the joint, and the external auditory meatus. And I think we're all kind of understanding that we've had patients that come to our practice that had said, I have an earache, went to the ENT, my ear's fine. And then my MD thinks I have, TMJ. And we say, and I'm thinking, yeah, everyone has a TMJ joint, but you know what they mean? They think they have temporomandibular joint dysfunction. So this is just more kind of a screenshot for everyone here. And it's just kind of tying in, I think, the four money muscles. Right, so we've got the temporalis masseter, medial pterygoid, and lateral pterygoid muscle. The little top line there you see on your screen is the function, and we have our three elevator muscle activities that are listed: the temporalis masseter and the medial pterygoid muscle. And then we've got the trigger point, or the pain referral patterns, or the heterotopic pain, where site and source is not the same. So as you can see here, I'm looking through, we've got some ear stuffiness coming up, we've got some joint pain, and that's not related to the actual joint itself, but it's the pain referral pattern. So definitely hyperactivity of these muscles. If there's an incoordination, if there's occlusal muscle disharmony, perhaps the condyle disc assembly is not seated, and for whatever reason, their maximum intercuspation is in a completely different position, and all these muscles have to work pretty hard to function and stabilize the joint. So in my mind, when I think about muscles, I want, centric relation is an orthopedic position where bones are stacked. Anything else outside of that position, all these muscles have to contract. All right. So let's go into all the different sort of types of anterior deprogrammers. The first one being is the quick splint. This is such a big tool in my toolbox. I'm going to start with this one here first. It deprograms muscles, which we talked about. It seats the condyle. It releases the lateral pterygoid muscles. You can use it prior to records. In a couple of weeks, the patient can come back and you can take the record. It's also a provisional protective appliance. You can diagnose whether it's joint or versus muscle, and we briefly touched on that earlier. And you can transition this appliance to a full coverage appliance if you need to. And the patient is equilibration ready, or the bite harmonizing procedure, as I called it. So steps for quick splint delivery. So these are 8 steps here. You want to try it in. There shouldn't be any tipping. You want posterior disclusion. You want to put adhesive on the inside of your quick splint. I use a Futardi, a Kentenbach. It's a very rigid material. It sets really quickly, works great. Then you want to seat it, and preferably you only want the centrals to touch. And you have the patients come back in a couple of weeks and you evaluate. Is it joints versus muscle? And if you need to take a record, you can do that. I have had patients immediately in this, in a quick splint, and they'll come back, or they'll even call and the first night I wore it, it's been extremely comfortable. My muscles are not sore, my headaches are better. And I've also had patients that said, doc, I hate to disappoint you, but this is a very, I just can't wear it. Actually my joint hurts worse. So this is a really good way to diagnose joint versus muscle. Now, I always tell patients in these appliance therapy type deals, it's like you're going to get better, you're going to get worse, or you're going to stay the same. And all of these 3 things are okay, because it's going to allow us to give us information to decide what's the next step for you. So there's a huge relief that they're not expecting to just all of a sudden get better. It's for us to learn about the next steps. So the next one is the leaf gauge. So I know everyone has this in their toolbox here. Also deprograms muscles. It seats the condyle, and it allows us to get the first point of contact, right? So we're using the leaves, we're taking the leaves out. It's doing the same thing principally. It's releasing the lateral pterygoid muscle. We're using it prior to records. We're capturing centric relation and understanding centric occlusion. We're putting bite registration material right in between so that you can transfer that bite registration material and mount it. And we're also, some of us are using it for an equilibration tool. So those are all the things that we can utilize a leaf gauge for. Next one on my list, we've got the diagnostic palatal anterior stop, DPAS, and the COIS. So they're both mainly, this picture here is the picture of a DPAS, but those of you that have a COIS deprogrammer, I know we're all going to say they really look very similar. There's no occlusal wraparound. It engages more the palate, and it delivers the forces to the palate, and it's not a tooth-dependent appliance. So again, it deprograms muscles, it seats the condyle, it releases the lateral pterygoid muscle. We're using it prior to records, transition, and we're also utilizing this as sometimes I'll transition to a full coverage appliance as well. And it's a great equilibration tool. You can actually you can start equilibrating the deprogrammer down, and then utilizing that as an equilibration tool. So what's really unique that I just want to bring your attention to with this is that there's very, very minimal interocclusal space. And I think that's the magic of these DPAS and the COIS deprogrammers. And the other piece of it is the forces are delivered to the palate. So lots of cranial bones are involved. And some will say the temporal bones are impacted by this. The sphenoid bone is impacted by this. So there's all sorts of total body connections that are related to this deprogrammer. And to be honest with you, I don't even think we fully understand the intricacies of how these appliances really work. So that's just pretty amazing. So then we're going to go to this, the Anterior Deprogrammer. So this was kind of the premise of, or my inspiration to have this talk tonight was around just anterior deprogrammers, also called Pankey bite stops and the Lucia jig. It is a diagnostic tool. This does not go home with the patient. As you can see how little that is, and I've even blown it up, but it really is that small. It deprograms muscles and muscle engrams incredibly well. It seats the condyles, it releases the lateral pterygoid muscle. You can also use it prior to record taking. We can transition to a full coverage appliance. We're also utilizing this as an equilibration tool. And I'm also utilizing this for a digital scan sort of bite for splint therapy. And I'll show you that later on. So there is a concept called sort of that muscle deprogram, and so the cranial reset. And so I want to touch base, and I just want to kind of keep going on this and come back to that. But I want to talk about the muscle system. So the muscle system is like an elastic band. So we alter one elastic band, it can change the head position. And I know, sometimes, I guess the simplest thing I can think about is, muscle position. If we're delivering a crown with the patient sitting back and the patient bites, and when this patient's sitting up, the head position changes a little bit, and it's actually more accurate to check occlusion in a little bit more of a supine position. So, it's really, really dynamic. And if one elastic band in the muscles is altered, it can change your head position. Then we go into how intricate the bones are. So we're just specifically thinking about the bones in the skull. So there are 22 bones in the skull, and the sphenoid bone articulates with 11 of these bones. And so these photos are, I have to credit Dr. Herb Blumenthal. These are from his slides, and he would just sit there and just go over all these bones with us and just say how amazing the sphenoid bone is. It's the butterfly-shaped bone, and that in our skull, there's over 100 articulations. And so interestingly enough, the temporalis, lateral pterygoid, and the medial pterygoid all originate from the sphenoid bone. So our elevator muscles attach to the sphenoid bone through the pterygoid plate. Our muscles of mastications attaches it to the sphenoid bone. The lateral pterygoid muscle attaches to the sphenoid bone. And so he always claimed that this muscle deprogram was so incredible because we talk about the war between muscles and teeth, as Pete Dawson would say in his functional occlusion book, muscle always win. And I think Herb Blumenthal took it to the next level and said, if muscles and bone war, muscles are going to win out. So I want to just put that out there because I think there's a lot of amazing things that the Anterior Deprogrammer can provide for our patients in terms of a full body connection. I have a physical therapist that comes to my practice one day a month, and we collaborate together, and we're doing bite splint therapy. And I think the most amazing piece of this is we're just kind of talking the same language. We're talking about, feet and teeth communicating, and he shared this article with me where there's an unequal posterior occlusion. It may cause posterior disharmony and lateralized gravitational challenges. And so basically, however our posture is and our positions of our teeth coming together, our occlusion, it really is important in treating the whole person. So here is a patient. I'll just kind of paint this story here for you, but here's a patient. She came into my office, some jaw pain, popping and clicking, and then she has an anterior deprogrammer in. Again, this is the anterior only deprogrammer. This does not go home with the patient. This is a diagnostic tool.
Side to side, left and right. Okay, now open, close, open, close. Okay. So what just happened there?
I'm able to open my mouth more, and the pain is gone.
It's gone. Yeah, I put it in there and
And there is no more popping.
and the popping stopped in that.
Yes.
Okay, go ahead and open, close, and open, close. first
Yeah.
time, and then it's seated, and then it got better the second time there.
Yeah.
So, how would you feel like if I gave you an appliance or a dental orthotic that could help you feel like this?
I would love it.
Yes.
All right, and here's another one, an anterior deprogrammer, and this is, we already did the diagnostic test. I put the anterior deprogram in, and I'm just talking to her. This is Corey.
Hey, Corey. It's your first time here at the office. It's nice to meet you. And you initially came to the practice with some symptoms of just head and neck and jaw pain. Can you describe that?
Sure. Yeah, my biggest symptom was my ear pressure, and I think a lot of migraines, and the biggest was my ear pressure.
Okay. And so we did a sort of a initial exam together, and I was able to kind of go through and sort of palpate or check your muscles. And we found that the muscles on the right side were a little bit tighter than the left, and same thing with that pressure around your ear, right? Now, I put in what we call an anterior deprogrammer. Okay, it sort of relaxes the muscles, and it seats the what we call the condyle, and it allows the pressure tension to become less. And so, can you sort of tell me what you're feeling now after we put that little bite device in?
Yeah, so this morning when I came in, I did have the ear pressure, and when this device was put in, the ear pressure definitely minimized.
And we also did the head rotation. Tell me about that.
So yeah, my neck feels like it has less resistance, and it's not as tight.
Okay, awesome. And open up wide and close. Open and close. Do you feel like you have better range of motion when you open as well?
I think so.
Okay. Okay, wonderful. Thank you.
Awesome. So those are two examples of how I utilize an anterior deprogrammer in my practice, and I always end with, let me see here. And I always end with, what do you think happened here? And honestly, the best response I ever got was, they're like, I think this is voodoo. This is incredible. And what's exciting is patients are then coming back and saying, I want to feel like this. What do I need to do? And seek out treatment. So it's just a really great way to include and involve the patients. And I also want to see from a diagnostic standpoint, if what I think therapy is going to look like, if it's going to benefit the patients, or if it's mainly muscle, or if it's a joint issue as well. So this is Dr. Herb Blumenthal's 10 steps of muscle deprogramming. I just kind of came up with this because this is exactly what I envision him doing, and this is what I actually do in my practice. So, a power of observation is so incredibly important. We do a preclinical interview, getting the story. If we get the story, pretty much, we always say we already have half the history, and we really have a really good idea of what's going on. We do a full muscle and joint exam. I always do a head rotation test as a baseline, because they could have some neck involvement with overall treatment needed. And I talk about the diagnostic tool explanation, and I grab my anterior bite stop, my Pankey bite stop, and I put bite registration in there. I make sure that there's no tipping. So that little thing, I don't need to put any type of adhesive in there, because it just kind of locks in, and it's just a diagnostic test. Again, it does not go home with the patient, and I'm making sure that it's perpendicular to the arc of closure. I don't want any tipping, because I don't want to distalize the condyle, and I just have the patient, tap, tap. I also do a really nice diaphragmatic breath and just make sure the patient is really relaxed, so the muscles really have a chance to relax as well. And I have the patient tap, 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 open and close, and go side to side. And this is something that I learned from the TMD courses and from Dr. Herb Blumenthal. It's this like quick guided tap on the deprogrammer, and I call it like the reset button. So something about that triggers that muscle deprogramming, breaks down the muscle engraps, and it just kind of resets the craniomandibular connection. And then you repeat. You go back to 6, you repeat it again, have them tap, 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 slide around on the anterior deprogrammer. Again, there's no posterior teeth touching. And then you go get coffee or check hygiene. And you come back and you check the muscles and the head rotation, and there's a lot of co-discovery just in in those two patients, it was just within, honestly, minutes. In minutes of it, the condyles, I got a better condylar seated position, the muscles will start to relax, and it's been so extremely impactful. So I, hope this was a really good summary in the different aspects of what anterior-only appliances can provide, and understanding what it means by anterior deprogramming now. I want to talk a little bit about sort of the digital dentistry platform now with splint fabrication. And I know most of us are solely making splints digitally. We probably work with a dental lab doing that, or some of us are making shells. But however that process is, I just want to remind everyone, I love this quote. It's the man who grasps principles can successfully select his methods. The man who tries methods ignoring principles is surely to have trouble. There's so much in our digital dentistry world where we're taking scans, and hopefully we're just providing our laboratory, and we're providing the patients with the information that we need for splint therapy. So in this case, I would take the scan top and bottom, and I want a close to seated condylar position. So here I'm utilizing the anterior deprogrammer as a way to give myself a hands-free centric relation record. So I put the material in, I guide the patient, and stay tuned. I think I'm going to put a video in the Curator Journal on maybe implementing this. So I'll share the video with everyone, but it's a hands-free way. I put a little compound wax at the end, so I'm locking in that specific seated condylar position, and I'm just putting blue mousse. I had a conversation with my lab. I was not doing it this way before. I was using the anterior deprogrammer, but I wasn't locking it in. If there was any type of micro movement, when they were going back and they were looking at the scan, he would get two different bites. And so this is really streamlined and given me some confidence that I'm starting the position in appliance therapy in a seated condylar position. So I'm utilizing the anterior deprogrammer as a way to take my record now, which is awesome. We also give them a protrusive picture, which is for condylar inclination. And so this is to ensure that you have the sort of an ideal steepness to your appliance, because an ill-fitting splint, or especially a very steep splint, can have just the opposite effects and make the patients feel worse. So if you're not in practice of giving them a protrusive bite, just taking a quick picture, even with the cheeks retracted with the retractor and having the patients go end to end, you're able to give them the information about the condylar eminence, and they'll be able to properly put the steepness, or the shallowness, I should say, in your appliances. So that's another pearl on how to create some successful bite splints. Another application that I started to do that I wanted to share with everyone is just, I do a lot of aligners. So if I'm doing Invisalign and I'm finishing up and I noticed, that the patients had parafunction and there's wear, and if I'm thinking about the restorative dentistry at the end, I'm putting these little bite ramps in there, and I'm actually, this picture has 4 in the anteriors. I actually like to put mine in the canines now, because I feel like there's a lot less interocclusal space if you put it on the canines. But you can actually put those bite ramps in there, and what have we now created? An anterior only appliance. So then now you're transforming your Essex retainer, your Viveras or your excess retainer, and you're making it just now a anterior only appliance, which is great, because it's the disclusion of posterior teeth that decreases the elevator muscle activity. So as we're looking at some cases like this with severe wear, and we really don't know where to start, we really want to think about having a diagnosis first and then creating a working diagnosis. And what I want to share with everyone about the working diagnosis is we reserve the right to change our mind. There's a lot of stuff going on when patients need dental treatment, and we need to work through and make sure we understand their overall dental plan, and that working diagnosis really helps us to get there. So this is like pillars in architecture, really, really important. And I consider these major pillars in dentistry, where we're looking at joint, occlusion, muscles, airway, the craniomandibular connection. And the systemic health is important. And we're looking at form, function, and aesthetics to be able to treat the patient from starting from a healthy TM joint and taking it all the way out to a healthy, beautiful smile. So in the last few minutes that I have here, let me show you a really quick case. I have a full documented case on this, but just so in lieu of time and for this presentation, I'm just gonna kind of show you maybe the major principles. So this is Jared. He's a police officer in his 30s, and main thing was, you know, he's got some chipping in his teeth, and he just wants to address, he wants veneers. So I talked to him about this. We do a full comprehensive exam, and this is what I learned. Kind of the premise of our talk today. I do a functional occlusal exam, and I feel fremitus. So there's kind of wear on his teeth, as you can see on the upper right picture there. He's got some indentation. He doesn't have an even occlusion. He's kind of hitting on those premolars first, and he's sliding in anteriorly, and so he does not have a seated condylar position, and I find that he has a first point of contact and he's hitting and sliding. So I'm thinking envelope function violation. I'm thinking about the position of his condyles. So I decide in this case that, and with some of the things that I'm finding here, so I decide, okay, well, what do I do, right? He wants veneers, and he actually pointed to number 7, not looking like 10, 8 and 9 are uneven. So totally understand, and I think we can give him a nice aesthetic outcome, but I'm more sort of thinking about, okay, we've got sensitive teeth, we've got chipping, I've got fremitus, he's got parafunction, he's aware that he bruxes, I did some muscle exam, he's got some muscle soreness, you know, and ultimately, you know, occlusion plays a role. So I'm thinking, all right, well, now what? So it's like, obviously, I want to incorporate some type of appliance just to make sure I've got a really good seated condylar position. He's not in centric occlusion. I would like to start there. I want occlusal stability. I wanted to make sure that I have a really good starting point. So with that being said, I decided that I was going to look into an anterior only appliance. So again, his case satisfies deprogramming muscles. Wasn't really getting the headaches, but it's going to allow me to seat the condyles. He's going to release the lateral pterygoid muscle. We're going to protect the provisionals for him at the end. I'm going to use the appliance. I'm going to use a quick splint to help me with that. And it's going to help me to assess, just have a better diagnostic knowledge about next steps. So I used the quick splint in this case, and he's in it for a couple of weeks. And during the veneer preparation and during that provisionalization stage, I used the same quick splint, change the liner, and use that now as a protective appliance until his final case is delivered. So he's in the quick splint, he comes back, and we do the dental facial analyzer. I do a trial equilibration for him on the model, and I call it bite harmonizing. And actually what was really amazing for Jared, he was like, oh my goodness. He's like, thank goodness you're looking at my bite, because I don't think my bite is even at all. So he was just really open and welcome to the fact that we're starting from a solid structure, healthy joints, even bite. And then I said, Jared, we can then do the dentistry. Then that's a go. So super excited about that. I'm ready to stabilize his occlusion. I'm ready for dentistry. So I have him come back, and these are my before and afters. I start equilibrating him. He feels great. I feel like I have more restorative room because he's in a seated condylar position, so he's not colliding on his anterior teeth anymore. So all of a sudden, I have a little bit more restorative space, which is awesome, and that's what I needed. So we do the digital smile design, you know, this full face photo is really important. So I work with my lab and we do a smile design. We're looking at the length of the teeth. And so we decide we're going to go longer for obvious reasons here. And I do a trial smile for him. We look at the wet dry line. We're looking at phonetics, aesthetics, and all those things that we would to make sure that the final restorative outcome is going to be predictable and aesthetic. So we decide we're going to do the 7 and 10, obviously, and then you know, he does a take-home bleaching. I get initial start shade. I use my polarized filter, really document the shade really well. I then go ahead and I use the putty matrix. I do the trial smile and I cut back from that. So that became sort of I prep through my prototypes, which is really helpful because I realize that it can be an extremely conservative preparation. I send shades to the lab. As you can see, just the overall workflow. This is exactly how all of my cases flow. We've got the before and after prototype. So he's in a provisional at this stage. He really likes it. Shades go out to the lab. All of that communication goes out to the lab and we deliver his case. So 7, 8, 9, and 10 are delivered. I always like taking a protrusive shot because I think that 8 and 9 should ride evenly with the lower incisors. It's really healthy for the jaw joints and for occlusion. So I love taking this shot to check my work. And he's in now, and that's his final case. So that's how we worked through. And obviously, even before I could say anything, he was like, all right, Dr. Lee, what do we need to do to protect my dentistry? I'm like, I'm so glad you asked. So I make him an upper splint. 90% of my splints are on the lowers, but I felt like in this case, I could satisfy or fill as many buckets for him as I could by making him an upper one. So we now call this a bite protective appliance, a muscle relaxation appliance, a joint protective appliance, and all the 3 things are in one appliance. And I said, please just wear this at night and please protect your dentistry. So that is kind of the overall flow, and my passion in dentistry is always start from healthy jaw joints, and we took that to understanding muscles. We now know where splint therapy, specifically from tonight's talk, where anterior only appliances fit in. We can utilize that to take records. We can create stable occlusion. We then can go into the design process, the fun part where we're designing smiles and we're doing the dentistry and we're delivering the case. And now we're circling all the way back and we're saying, okay, now that I have everything that I need, everything is delivered, what do I need to do to protect the dentistry? So we then now finish with another appliance. So I really strongly believe in this type of process. And I think what makes dentistry so incredibly amazing for us and why I think I love dentistry so much is that we're merging science, evidence-based dentistry, and with our artistic ability to be able to create and mold and deliver beautiful dentistry for our patients. And one of my favorite quotes that I'm going to leave with everyone tonight is, patients carry their own doctor inside. They come to us not knowing that truth. We are at our best when we give the physician who resides within each patient a chance to go to work. So I really appreciate your attention, and this is a little bit like speed dating. I was talking in like 1x, 2x speed, just so everyone had the ability to have the full scope of tonight's talk. Now, if there's slides, if there's information that you want to learn more of, or if I don't get a chance to answer everyone's questions tonight, and I am happy to kind of talk to you afterwards. This is my email. That's my Instagram. I also have Facebook. However way you want to reach out. We also always have education posting, and we do, and I do other webinars as well. So I think I mentioned earlier that we do so for those of you that are interested in learning more about sort of appliance therapy, different uses, and kind of getting into sort of the detail work about that's that's my Charlie over there. If you want to learn more about appliance therapy, the Essential series at the Institute is actually really, really awesome. I actually teach Essentials too, and that will cover everything from TMD, occlusions, all the splint therapy, and equilibration. So it's a really, I mean, we geek out for like 5 days in a really fun, good way. We really learn all those principles. So I would look into doing Essentials 1 through Essentials 4. If you're interested, that would be a great, great place to start.